Okay. Okay, I can see people are starting to join in. So I'll start anyway with some introductions and an acknowledgement of country while people join the session today. So welcome everyone. Thank you for joining us today. My name is Leo Alfonso. I work in the International Relations and Partnerships team for the STEM disciplines here at ANU. My colleague Chami is with us today on the call. She is going to help me moderate the webinar today. And of course, we are joined by Associate Professor Brett Scholz, who, yes, will talk to us in a minute. So we're very lucky to have Associate Professor Brett Scholz with us today. I'm sure most of you already read his bio on the website, so I'll keep the introduction very short. Brett is an associate professor and critical health psychologist in the School of Medicine and Psychology at ANU. In addition to his academic roles, he has served as a board member for the ACT Mental Health Consumer Network and has been co-founder and chief research officer for the SPORT projects. His research focuses on making health services equitable or more equitable, challenging power dynamics, and ensuring they are led by consumers, which brings us to today's topic. And with that, I would like to hand over to you, Brett. And again, thank you very much for your time today.
Thank you very much for that introduction, Leonardo, and hello to you all. It's I've been looking forward to this presentation for a while. Leo's already acknowledged country, but I know that some people are joining us from all over the world. And so I wanted to start actually with a picture that locates us very much on Ngunnawal and Ngambri country. This is a photo from one of my early morning walks. This is only about 10 minutes away from my house, and just sort of showcases some of the very beautiful sites that are very close to the Australian National University. It's a privilege to live on Ngunnawal Ngambri country, and I think it's important, as Leo already has, to pay our respects to Indigenous colleagues and communities around us, partly because this whole presentation today is about how we make sure we're including communities in our health services, in our health policies, systems, research and education, how we're making sure that health is an inclusive system and how we co-create health with communities. But we'll get to that. I guess there's two things that I hope you all walk away with after today's masterclass. I hope that by the end of the masterclass, you'll be able to, first of all, distinguish between approaches to patient involvement in health that are more tokenistic and approaches to patient involvement in health that actually share power with patients. I guess approaches that are about partnerships and where patients are leading the development and delivery of health policy services, research and education. And the second thing that I hope you'll be able to take home with you after this masterclass is to identify steps that can be taken to make sure that health policy, services, research and education are developed by and with patients or people working from lived experience perspectives. So I guess the crux, the main argument and what I will be speaking about today is making sure that whatever we do in health systems isn't just led by doctors, nurses, and allied health professionals, but rather patients or consumers or service users. I guess also before I start today's masterclass, I want to acknowledge that I actually don't work from a lived experience perspective. I am an associate professor in the School of Medicine and Psychology here. I'm actually a psychologist by training, so I work from a psychological perspective, but a lot of my collaborators are patients or consumers of health services. And it wasn't until quite far into my career that I realized that the people who usually have a seat at the table of creating, delivering, evaluating health policy, services, research, and education are typically doctors, nurses, and allied health professionals. And it's often patients or consumers who are excluded from developing policy, implementing services, or evaluating research and education. And so I've got this image to kind of start us off and to make us think about the fact that it's these health professionals that sit at the table where all of the decisions about health systems are made. And patients aren't sitting at that same table. They might be off at some table in the background, as you can see in the distance there, but they're not the ones who are establishing policy, who are implementing our services, who are creating and using knowledge. That's the crux of today's masterclass in a nutshell, but let's begin by defining some participatory terms. Already in the masterclass, I've used terms like consumer, patient, service user, lived experience. I will also be using the word citizen. And part of the reason why I've included this slide here is that I know that the audience today is quite international and different words are preferred across different contexts. And even within particular countries and contexts, different terms are preferred or dispreferred. I tend to use the word consumer because in Australia, consumer movements actually chose the word consumer to refer to them. But I would say it was chosen not by consensus. It's not as if everybody agreed that it's the best term to use, and not without some criticism. So there's certainly people who do not like the term consumer. Probably the word that is most widely understood when I'm talking about consumers, I'm talking about patients, people who have a lived experience of being sick or using health services. But again, the term patient is quite contentious, and there are some people who like it and dislike it. So it's not that I'm trying to say that all of these kinds of words are exchangeable, but I guess for the purposes of today's masterclass, if I use a term like consumer or service user or person with lived experience or citizen in the context of healthcare, I'm really talking about people who have been patients, who are working from a patient perspective, rather than people who are in the health system because they're doctors, nurses, or allied health professionals. I also will use, and you may well have heard of terms like co-design, co-production, co-creation, collaboration, or partnership with consumers. And again, these terms do refer to different things, and I don't necessarily have time and it's not necessarily relevant to define all of these terms. I just really want to flag that these are terms that may come up throughout the masterclass. They're all approaches to developing or evaluating or implementing or refining health policy, health practice, health research, or health education. I'll come back to some of these terms and discuss them where relevant throughout. And as I say, really at this stage, just wanted to flag that they all have some unique definitions and principles, but what unites them in today's masterclass is they're all a way of thinking about collaborations between patients on one side and doctors, nurses, allied health professionals on the other side in creating health policy, services, research, or education. So that's my definitions, essentially bringing that all together today in the masterclass. What I want us all to, what I am driven by is trying to ensure that people with lived experience of ill health or health service use are part of the planning, the implementation, the delivery, and or the evaluation of health policy, health services, health research, and or health education. The next section, I will be talking about why isn't engagement and involvement enough. You know, the title of today's masterclass is about moving beyond engagement and involvement. And so to set the scene, I'm going to share a graph that I keep coming back to through lots of different presentations, and I keep trying to update. I don't have a very good caption here, so I'll talk you through this graph. But essentially, this is not a formal bibliometric analysis. This is just a search I've done of the literature in the health sector that uses words like co-design, co-production, collaboration, partnership with consumers. Essentially, what I'm trying to show with this particular graph is that you can see in the past 10 years or so, or just over 10 years, there's been a huge increase in the number of publications about co-designing the health system with people with lived experience of being a patient. You know, it was less than 10 years ago that there were less than 200 publications about co-designing the health system with consumers. And just looking at last year, we now have over 1,000 and projected this year to surpass that again. It's definitely becoming very hot to think about designing the health system with patients. And so you'd think that would make me happy, right? That seems like it's a really good thing. There's a lot of growth and a lot of interest in this area. But actually, I feel quite ambivalent about this. I've had some colleagues who have said, oh, you know, there's so much interest now in collaborating with consumers on designing health systems, services, policies, education and research with consumers. We're actually in the middle of a participatory era. Somebody's called it a participatory zeitgeist. But as I'll kind of make an argument for over the next few slides, I think it's great that there is a bit more interest in this. I also worry that there's growing tokenism and that actually there's more people saying that they're co-designing with consumers and not so many people doing co-design with health service consumers. But actually, somebody who says it much more articulately than I is a consumer colleague of mine, Simon. And so I'll read this quote from him, who I think says it much better than I could. He says, co-design in social policy is a paradox. On the one hand, it refers to a transformative set of mindsets, tools, ways of knowing, and ways of collaborating to design better and better design services, policies, and systems. On the other hand, everyone seems to be doing it, but our services, policies, and systems remain the same. I think one of the useful tools to think about the extent to which power is actually shared with consumers in some of these co-design initiatives is a tool from the 1960s. Some of you may have seen Arnstein's Ladder before. This is a reproduction of Arnstein's Ladder, originally published in 1969. And Arnstein essentially wanted to produce a way of understanding the extent to which citizens had power over initiatives in policy. Now, this didn't actually originally come from a health discipline, but this ladder has been used across so many disciplines. It's been cited tens of thousands of times. It's been used a lot in health. I think it's a really good tool to think about the extent to which health services and health professionals are collaborating with consumers in initiatives and the extent to which power is shared in those collaborations. To just briefly talk you through I mean, some of it is probably self-evident from the ladder itself, but you can see that as you move up the rungs of the ladder, there's increasing power given or shared with citizens or consumers of health services. And you know, you can see the bottom two rungs, Arnstein considers that's not participation at all. You can see rungs 3, 4, and 5. Arnstein refers to those as tokenism. Those are things like consulting consumers on what kinds of health services they want or what kinds of health policies should be implemented. And then looking at rows 6, 7, and 8, this is what Arnstein calls citizen control. So those rungs refer to say, for example, policies developed by consumers or with consumers, services provided by or created by or with consumers, and so on. I'm particularly interested in those top two rungs. I really am fascinated by and want to see more of collaborations in which consumers actually have control over decision making and agenda setting in everything that we do in the health sector. And I think though, a lot of health professionals these days think that they should be rushing up those rungs and that they need to be up the top straight away. And I'm going to go to another quote from another consumer colleague of mine who I think she says it much more articulately than I could. And she says, it's good to move up that ladder. She's referring to Arnstein's ladder, but it's even more important to be honest. Being upfront about the limits of your participation process is one way to recognize power, avoid tokenism, and build trust. So in other words, yes, it's great if there's a health service or policy or educational research initiative that is controlled by citizens, but it's actually problematic to claim that a new health initiative or a policy or a service or a research education output we've developed, it's problematic to claim that that's been done by or with consumers if actually all we've done is consulted consumers or done something further down those rungs. And that's what I worry is going on here. You know, we spoke to earlier how the number of publications about co-design with consumers has increased almost exponentially in the past 10 years. Again, I think that's wonderful in some ways. I really worry though that some of those publications actually refer to more tokenistic rungs, or what, you know, Indigo would say from that previous slide, where people have actually been dishonest and have claimed that they have co-designed with consumers or that initiatives have been led by consumers when in fact consumers have only been consulted or they've only been involved in lower rungs of Arnstein's ladder. I guess actually, sorry, just before I move on to the next session, one more point to make about this slide is obviously there are thousands of studies now in this, and it's not that I've read all 1,000 of these studies or that it would be possible to do so. But in doing this brief, you know, constructing this graph, I did go in and have a look at some of them. And one thing I noticed is some researchers, some doctors, nurses, or allied health professionals are starting to publish papers where they refer to co-researchers, consumers as co-researchers, even in the text of the papers they're publishing. But when we look at the authorship lists, there's no consumers listed. When we look at the acknowledgements, they're not listing, talking about the consumers that they've co-researched with. And it's just indicative to me that there are claims that are being made that we're actually doing more co-design than what I think we're actually doing. And that's my concern. Okay, so you might ask me, well, what is beyond involvement and engagement? If the whole crux of today's masterclass is moving beyond involvement, but what might that look like? Well, one of my actually, she's just about to graduate, but a PhD student, Stephanie Stewart, who spent her PhD developing a definition of lived experience leadership. Her entire PhD thesis is brilliant and does a very thorough job of defining what lived experience leadership is. I've tried to condense that thesis into one slide. Probably haven't managed to do justice to all of the nuances of her work, but she found that lived experience leadership is a practice that is enacted in a variety of roles to affect change and improve consumer circumstances. And in fact, so looking at that first dot point, the roles were sometimes defined roles for consumers or sometimes not defined roles for consumers. And what I mean by that, here at least in Australia and with some international contexts as well, we're starting to see people advertise positions requiring people to work from a lived experience perspective. So one example of that here in Australia would be, for example, in the Victorian state government. So one of our state government's health departments has a director of lived experience leadership and requires that person to identify as working from a lived experience perspective, rather than being a doctor or a nurse or an allied health professional. But she found that lived experience leadership or patient leadership or consumer leadership could be enacted in one of those defined roles, or could actually be done even if somebody wasn't employed in a defined role. Moving on to the second dot point, she found that lived experience leadership requires lived experience and leadership capacity. So somebody, to be able to engage in lived experience leadership, somebody needs to be able to draw on their lived experience of being a patient, and a patient relevant to the context in which they're working. And the last dot point, she found that lived experience leadership is performed through a variety of processes, and those processes including collaborating, direct and indirect influence over decision-making, application of said lived experience, and development of inclusive cultures. I've kind of talked a little bit already about how I would like to see consumer leadership across health policy, health services, health research, and health education. I might actually go through an example of what lived experience leadership might look like in each of those contexts. The next slide is the next slide after this slide that I've just put up will give an example. These are not exhaustive examples of lived experience or consumer leadership in the health system, but just as a way for us to start thinking about what lived experience leadership might look like. And I've chosen these examples because they're ones that I can directly speak to and explain a little bit more. So let's look at policy first of all. So one example of I guess I've actually already given an example of lived experience leadership in policy, because I mentioned that government role that was created here in the Victorian state government in Australia to have a lived experience director working from lived experience. So that's probably a really good example of policy. But I've got another one here, which is in 2020, the process to triage COVID in intensive care units in the hospitals here in the Australian Capital Territory, which is the territory that the Australian National University is in and that I'm currently zooming into you from. It was actually developed by 26 different consumer, carer, and community groups. It was an example of policy that was enacted for 2020 that wasn't actually developed by doctors or nurses or allied health professionals like most health policies are. It became an official policy of our territory, and was kind of amazing. It was amazing to see that happen even in the context of COVID. An example of services that are part of a lived experience, that are lived experience led or can be lived experience led, are peer led services. So some of you might be familiar with mental health services that are peer led. It doesn't have to be mental health services, but there are many mental health services that are peer-led compared to peer-led services in other contexts. And this refers to, for example, a counselling service run by peers. Perhaps an obvious example that maybe everyone is familiar with, or many of you will be familiar with, is Alcoholics Anonymous. So that's an example of a service that exists internationally that is led by people with lived experience of alcoholism for people with alcoholism or alcohol addiction. An example of lived experience research, I actually have many listed here. I've talked about consumer researchers or journals or research funding assessors. Let's break this down. I mentioned earlier that I am a psychologist and I work from a psychology perspective. I personally don't work from a lived experience perspective. But in 2015, I started a job in a very small research center that employed 3 researchers. Me as a psychologist, my boss, a nurse, and the third person was a consumer researcher. So somebody who was employed full-time, just like I was as a psychologist, to do research from a lived experience perspective. Now, these kinds of roles are still uncommon, but have been growing. I think the world's first, that I know of at least, consumer researcher or consumer academic position was implemented in over 20 years ago now, actually. And I now know of a handful, so they still are relatively uncommon, but I guess have been growing over, a couple of decades. Another example of lived experience-led research is maybe a journal by consumers for consumers. And again, an example that comes straight to my mind is the International Mad Studies Journal. So that's a journal I've had a little bit to do with. So I know that 66, 2/3 of the editorial board are people working from lived experience perspectives. Now that's quite uncommon, I guess, in the broader research space. It's a bit unusual, but it's becoming, there is more interest and there's more understanding of this. In fact, even at the start of this year, or maybe the end of last year, The Lancet, one of the world's, arguably most important or certainly at least well-known or high impact factor journals, released a statement about lived experience research in publications in Lancet submissions. So it is becoming more and more important. But it's maybe not quite as fast as I would like it to be. I'm going to move on to the last domain here, which is health education. And I did already mention that, 20 odd years ago, the world's first consumer academic role was implemented. And I guess I have seen in the past sort of 5 or 6 years, there is an increase in consumers developing and delivering curricula. Particularly, I see this in the nursing space, but it is starting to appear more and more across other health disciplines as well. Essentially, the idea is that it's not just doctors, nurses, and allied health professionals who should be employed by, health faculties, but people working from a lived experience as well. So I guess these are all examples where, when we're talking about lived experience leadership, I'm thinking about ways in which people apply that lived experience to have decision-making or agenda-setting capacity in policy, services, research, or education. But as I kind of alluded to, and as that first part of the masterclass spoke about, there's a lot more engagement and involvement, and there's less examples of initiatives that move up the rungs of Einstein ladder. So there's, for example, there's more examples of health policy being developed through consultation with patients, and less examples of health policy being developed by patients. I've done a lot of research together with people working from a lived experience perspective to try and understand some of the barriers to moving up that ladder. And I guess one of the big barriers is that my lived experience colleagues tell me that they feel, much like in other minoritized identities, there's a glass ceiling. So you've probably heard of the glass ceiling effect in terms of, say, gender, whereby women are less likely to get senior leadership roles in organizations. Well, consumer colleagues say something happens similarly in the consumer workplace. They talk about how there's lots of entry-level positions to work from that are dedicated lived experience positions, but there's less opportunities to work in senior management roles, to have influential policy roles, to be, to break through that glass ceiling. And they talk about the health system as inherently hierarchical. Now, we know this because even within established health disciplines, I've talked a lot today about doctors, nurses, and allied health professionals. Even within those different health disciplines, there are power imbalances. there's a large literature on the way that nurses are excluded, for example, from lots of senior health roles, even though they by far outnumber doctors in hospitals. So the health system is inherently hierarchical. That's part of the problem. But there's also another part of this problem of patients not being able to break through that glass ceiling, is that this is a huge paradigm shift. Um, you know, doctors, nurses, and allied health professionals are inherently used to thinking about patients in a clinical sense of people they're taking care of. They're not used to understanding that patients actually have a lot of insight to offer health policy, health services, health research, and health education. It's a paradigm shift for them. And the other part of that puzzle is that we often devalue patients' insight as well. We assume that actually they lack capacity to be informing health policy or health service or health research or health education. And I'll talk about one more barrier from some of this work, which is that lots of my consumer colleagues talk about being excluded both physically and metaphorically from spaces in which decisions are made about health policies, services, research, and education. And the paper that this quote comes from, not in the room, but the doctors were, comes from some data that we collected to try and understand how consumers felt when they were collaborating, when they were serving on committees in hospitals, or when they were part of initiatives to develop health policy. And I mean, this played out in many ways. One of the ways that was really quite visual to me, or one way that I could picture really clearly in my head, was some of the data that we collected where people talked about having to be the consumer, one single consumer, walking into a room of, 10 doctors, 15 nurses, these senior health professionals, when everyone's part of a committee, but the consumer's the person who has to sort of be let in the special room, or swiped in at the end, or given everyone's staring at them as they walk in. They physically have felt like they're not part of the team. It also played out in some other ways in our data, and I'll mention one other way now because I'll come back to it in our closing slides. Another really interesting piece of data that I enjoyed was about karaoke. So one of our participants talked about the end of year Christmas party that the health service put on. And it was a karaoke party. And obviously this probably seems a bit funny because I'm talking about developing health policy and health services and health research and health education, very high level, health systems thinking. But this participant said that actually some of the decisions were made in between karaoke. Some of the discussions about policies that would be implemented didn't just happen in the committees or the very formal structures. They actually happened in some of the informal spaces, including, at the party, or sometimes it was just at the lunch room or whatever. But essentially, I guess in our health institutions, we're physically and metaphorically excluding patients from the places where decisions are being made. I'm going to move to the final sort of phase of today's masterclass, and I want to leave you all with sort of 5 things that I'd like everyone to be doing to start thinking about how to bring about more lived experience leadership. So there's a growing arm of research that looks about allyship. And when I'm talking about allyship, this is acts that other people can do to bring about more consumer leadership, to bring about more of us moving up those rungs in health systems, policies, services, research, and education. And some of these are big things that require a lot of thought and resources, but the first one is something that, I think that lots of us can do anyway. So the first thing is I'd love us to celebrate consumer-led or co-produced work. And that could look like a lot of different things. This could look like reading research that consumers have written. Often, if I'm starting a new research project, for example, I will do a little Google Scholar search to look for consumer-led research about X, Y, Z, whatever it is, the project's about. Even just simply reading that work is something that any of us can do. If we're doing anything in the health sector, first of all, just having a look for some of it. In some disciplines and in some areas, there will not be a lot of consumer-led work, but even just seeking it out is a great first step. And then the second step I put here is tell people about this as well. This is an although I critiqued earlier the idea that we're moving into a participatory zeitgeist or some kind of participatory era, we are moving into an era where there is increasing emphasis on consumer-led health services, health policy, health research, and health education. So people will be increasingly interested in consumer-led work. Tell people about it, post about it on your LinkedIn, share it on social media, have a conversation tonight with a friend about this presentation and how you want to look for lived experience-led work. So that's hopefully that first one is something that lots of people can do. And the remaining sort of 4 acts are potentially, it depends what kinds of resources you have access to, but things to start thinking about include not settling for lower bars of co-design or engagement or involvement. So as I mentioned early on, there's a lot of emphasis on co-design, consumer engagement, patient involvement. If we start to, if you hear of a conversation where somebody says, oh, let's work on a new initiative and let's make sure we're engaging patients, let's not just, maybe we can have a conversation to say, let's not settle for engagement, but can we actually make sure there's structures in place so that consumers have some decision-making power or some agenda-setting power? And that actually moves us beyond engagement and involvement. That moves us into those upper rungs of Arnstein's ladder, where power is shared with people working from a lived experience perspective. The third thing I think we can think about is being mindful of what hats you are and hats other people in the room are wearing. Let me explain what I mean by this, because the metaphor may be unfamiliar to some. And actually, I'll explain what I mean by giving an example of what I see very often when I'm, walking into a committee in a hospital or in a health setting. I've often seen people sitting around the table and somebody, let's say when we're developing a research project, and someone will say, oh, we should get somebody with lived experience of this disease to be part of our team. And then someone else in the room might say, oh, it doesn't matter. I have lived experience of that. I can be the person to provide the lived experience insight. When actually that person has been brought into that space because they're a nurse or they're a doctor or they're an allied health professional. They're not actually working from a lived experience perspective. And so they're actually offering their lived experience to exclude. Whereas what I'd love to see is those people making their lived experience as an opportunity for further inclusion. So what I'd like to see is when I walk into, a meeting, somebody saying, oh, we should get people with lived experience around this initiative. And then somebody saying, oh, yes, I do have lived experience of that, but my role here, or the hat I'm wearing here, is as a nurse or as a doctor. And I think we should open it up and include other people with lived experience rather than excluding people with lived experience. My fourth call to action is to make sure that people with lived experience are in the room. Now, whether that's going back to the example I was talking about before, whether that's the karaoke party room or whether that's, a committee room, I guess what I would like to see is any new initiative in the health sector, whether that be policy, service, research, or education, which I keep coming back to today, to making sure that there are people working from a lived experience perspective in whatever room you're in. And I guess including them in our informal meetings as well. Not just the committee, but any time that decisions may be made. And maybe that is our end of year parties or karaoke catch-ups. My last sort of call to action is to build. I guess I'm very mindful that a lot of what I say in this space comes across as very critical. I'm critical of people co-opting co-design, co-production. I'm very critical of people saying that they're engaged in partnerships when they're really at a much lower rung of the ladder. But I also really want to acknowledge that we all have to start somewhere. We don't all start at the top of that ladder. And so I don't want my critique to be a reason to not try to seek including people working from a lived experience perspective. So I hope that my critique is seen as a call to keep building and to keep moving up that ladder. But I go back to the words of Indigo Dyer, who I mentioned earlier. She's the one who said, it's good to move up that ladder, it's good to build, but it's even better to be honest about where you are. So even if you're still building, and even if you're just taking your very first steps today in thinking about how to collaborate with people with lived experience, I just want to acknowledge that we all start somewhere. And the more that we all collaboratively build together, the better. I will actually leave it there. There's some relevant references that I've put on this slide, but I'm always happy for people to reach out to me. There's contact details there if there's any clarification, or if you don't have access to any of these papers that are relevant to today's presentation and you do want access to them, always happy to share. And I think that we still have some time for questions. Is that right, Leonardo?
Yes, I was just finding the microphone button there. Yes, we do have some time for questions, and I encourage the audience to submit them through the Q&A. And none has come as of yet, but yes, I take the opportunity to thank you, Brett, again for your time and for what has been a very, very interesting masterclass. I was taking a lot of notes as we went along. So yes, just I'll get the conversation started to see if our audience then submit some of the questions. So something that I guess struck chord with me is the importance of moving away from tokenistic initiatives, and actually I put the word engaging, but then you don't use the word engaging. So I, scratch it and say sharing power in meaningful ways. Oh, and I think that goes across different sectors, not only in health services. And we can see that. And I was thinking as an example in my job here at ANU, where I have to engage students. And this Saturday, we had an opportunity to present to prospective students. And we actually call on current students to come and share their own experiences to the parents, because I was thinking, well, these parents are going to send their students here to ANU. Why would they want to hear from me? So anyway, that really resounded with me. But back on topic, did you mention early on your talk about the policy here at ACT that was co-designed, right, for COVID triage, sorry. And you use the word amazing to describe it. Why was it amazing? If you have any specific examples, what do you think? Yes, what's so outstanding?
Yeah, thank you. Great question. And I just before I answer the question around the COVID triage, I actually do think I agree with you about in education as well. It's I take your exact point. You know, I guess I have been a university student, but it's been years since I have, and I think the experiences of our current students can say a lot more about what it's like to be, you know, part of our university student community than I could. So I think it's such a good example, and I think probably most sectors could benefit from. It's essentially just making sure that the people who are having some kind of decision making and agenda setting power include people with direct, relevant lived experience. So great example, not too far off, of course, at all. Um, so your question around the COVID triage, there was a few things that were amazing about this. I think when I looked at the ways that and I guess I can only speak to other Australian settings. I don't know what happened outside the Australian context at this time, but in 2020, all of a sudden, everyone in the world were facing this kind of pandemic. We didn't know what was going to happen. Most hospitals had, you know, very limited capacity, so very limited respirators in the intensive care wards, and certainly not enough respirators in intensive care wards that would be needed if we actually reached, you know, a certain level of outbreak, which some countries and jurisdictions around the world reached much earlier than we did in Australia. And across the other states in Australia, none of the other states co-produced with consumers that triage process. Most of the others only included doctors, nurses, and allied health professionals. And what I noticed was different is that our triage process here in the Australian Capital Territory was actually based on human rights principles. So by being inclusive and by engaging with 26 different consumer carer and community groups, so this included, you know, people living with disabilities, this included Aboriginal and Torres Strait Islander Australians, this included older Australians, this included people living with various intellectual disabilities. It was a really broad section of the community who were very worried about being excluded from fair access to care. And it meant that the triage, based on human rights principles, didn't actually exclude people just because of very arbitrary things like age, or very arbitrary things like whether this person's quality of life was likely to be impaired because of an existing disability. Whereas what happened in other jurisdictions, they did actually have things like discrimination based on age or based on other factors. So it's just, it's something that I think doctors and nurses and allied health professionals wouldn't have actually thought of, because in their world, they're thinking about how do I deliver the best care to the largest number of people in XYZ parts of time. But they, you know, it required this community engagement and this community-led approach to really come up with a novel, innovative solution. And actually, sorry, one more thing about what was amazing about it is it struck me at the time. It was a very difficult time to do lots of things. You know, we were all suddenly on Zoom all the time. We all suddenly were in lockdown. None of us knew how to do anything. We were all had to learn very quickly. And it struck me that even in the context of we're all working from home, we're all on Zoom, we're all stressed, we're all worried, but we've created this policy. And if we can actually make sure that policy is developed with consumers and carers and community groups, when we're struggling with a new pandemic, I think we can do that anytime. You know, there's nothing that should be able to stop us now when we're in a very different position and we don't have to, you know, be dealing with a new pandemic all of a sudden. So that's the other amazing thing. You know, we can actually do this if there's interest, if there's capacity.
Yeah, great. Yeah, thanks for that. Yeah, I guess again, it highlights the importance of what we're talking is just bringing together different perspectives, right? And try all together to solve, in that case, was a common um, problem. Um, Health professionals are not doing what they were doing with because they wanted to be mean or bad. They were just having their own perspective, and as you said, trying to give the best care to the people who needed it. But it is only one of the perspectives of the problem, right?
Thank you. I think that you articulated that so nicely. And I think, I can be very critical in this space, and it can come across, I think, at times of saying, oh, we shouldn't listen to doctors or nurses or allied health professionals. But you're quite right. That's not what I'm saying. I'm
Mm.
just saying that the perspective is synergistic, and actually, it's it shouldn't be revolutionary to say that, oh, if we all work together and we bring all these diverse perspectives together, we can come up with really innovative ideas, but it still is not the norm yet in the health sector.
But it is revolutionary sometimes, right? But
Mm.
it shouldn't. And I guess it brings me to other of the notes I took, and I came back taking notes again because you talk about a shift in the paradigm, sorry, and yes, just changing that mindset, perhaps, of what level of power consumers have compared to yes, service providers, to doctors, to nurses. Um, and then I was thinking, well, if you have any ideas on how can health organizations or governments, policymakers ensure that lived experience are not only included but also empowered in the decision making. Now, I know you mentioned in big terms, in high level, yes, we need to do a shift in paradigm, but any practical ideas you have, perhaps, or examples?
Yeah. Two things come to mind straight away. One study that we did a few years ago looked at, actually, if we want to receive the benefits of the expertise of patients, then we need to actually make sure that patients are provided with um, opportunities to do so. It sounds so simple, but even simple things like making the acknowledgement at the start of a new initiative that we actually need patients, and saying things, showing that we want to value that expertise, meant that people working from a lived experience perspective were more willing to share their expertise. So there's kind of a give and take, I guess, necessary. Um, we drew on some, and again, this is not my specialty, this was a colleague's specialty, but we drew on some business literature that kind of talked about more synergistic approaches. So it could even be little things like some of my consumer colleagues say, when they come to a meeting as a part of a committee meeting in a health service, they have to print out the notes for the meeting on their own computer, and it costs them money, and they don't necessarily have that. Whereas all the doctors and nurses who are coming to the same committee meeting, they can print out the notes on the company or the
Mhm.
hospital. And it's a little thing because, for one meeting, it might only be a few dollars worth of printing, but it's just a very little thing that if we're making sure that we are printing notes for them, they're they can see that we are valuing that expertise, even just in a little way, and they're more likely to bring their expertise and let us, engage with and collaborate and use that expertise. So that's one thing. And the second thing is, I think that it needs to start early as well. It needs to be built into education, so that, each successive generation of health professionals is, graduating from their medical, nursing, or allied health degree, having seen their lecturers co-produce, co-deliver curricula with patients and kind of modeling that behavior. And we've done some studies on this in the nursing context, and there were we collaborated with a large European Australian group of universities who were co-producing, co-delivering curricula with mental health nurses and mental health consumers. And the students who graduated from those courses had less stigmatizing attitudes towards consumers, felt more confident about being professionals, and were more well positioned to collaborate with consumers. So I think we need to start overhauling the education system so that working with consumers is a part of everything that we do.
Thanks for that. Yeah, all very insightful. All right, we are almost at the time. Very interesting. Everyone in the audience is still connected, but no questions have been submitted. So I think that explains that, it has been a very insightful, and everyone got all the information they were expecting to get out of today's session. So I thank you for that. So I think, yes, with 1 minute left on the clock, I think I'm going to say thanks again to you, Brett, for your time. Thanks to Tammy, who has been there, also joining us, and of course to all our audience here today. Thank you very much.
Thank you.